Hello, everybody. My name is Joseph Hiddy, and today I'm going to present lateral and medial epicondylitis. Alrighty, so to get started here, you're at your outpatient clinic, and a 50-year-old male carpenter who presented with 2 months of lateral right elbow pain, reduced grip strength, and pain with extension of the wrist. Physical exam shows tenderness on the lateral epicondyle and tenderness along extensor muscles. There was no trauma to the area and no other relevant history. So I'm going to take a moment here and as you think of what this could be, that's right. Lateral epicondylitis, also known as tennis elbow. So, this is the incidence of this type of epicondylitis is about 3.4 cases per 1,000 person years. About 1 to 3% of adults have this, and comparable rates amongst males and females. The highest prevalence is in people that are ages between 40 to 49 years old. And then the second highest demographic would be between 50 and 59. Some risk factors to consider includes tobacco use, high physical load, activities and strain, and obesity. Classically tennis, but not necessarily uh, directly related. Anatomy. So lateral epicondyle of the humerus is where the pain is located. Um, it's important to note for board examinations, the key muscle is the extensor carpi radialis brevis. And then there's also the common extensor tendons. The etiology and pathophys of this disease, it's repetitive extension of the wrist and pronation and supination. It could also happen idiopathically. Um, this epicondylitis is a misnomer. New studies have shown that it's more appropriately named a tendinopathy, considering there's no epicondyle inflammation. So this disease is caused by chronic degeneration of tendons at the humerus joint origin. They found that there's increased IL-1 alpha, TNF, and macrophages compared to the unaffected tendons. Also, they also find angiofibroblastic tendinosis, which is consistent of fibroblastic tissue, vascular hyperplasia, and disorganized collagen. So the presentation. You have a patient that comes in, they usually are going to complain of lateral elbow pain, usually without trauma. It's a gradual onset and worsens with arm use, repetitive elbow, wrist, and forearm movements, and lifting objects. A classic example is a patient who has pain while lifting their coffee mug in the morning. Some differential diagnosis to include and to look out for includes osteoarthritis, which is more consistent with joint line generalized tenderness and limited range of motion. Radial tunnel syndrome, which proximal forearm pain and tenderness from radial nerve branch compression. Uh, and then also ulnar nerve compression, which is most consistent, presented with medial elbow pain, numbness at the fourth and fifth digits, like in cubital tunnel syndrome, and then also neuritis. So how do you diagnose tennis elbow? History and provocation testing. So some exam findings to look out for. The Cosen's test is a classic one. And essentially what you do is place thumb over the lateral epicondyle and then tell your patient to uh, pronate their fist and hold their hand in a fist, radially deviate it, and then extend it with the resistance of the examiner. A positive test would be pain over the lateral epicondyle. This exam has a 91% sensitivity. The next physical exam maneuver can be used is the Mills test, which is when you fully extend the patient's elbow and then flex their wrist and pronate their forearm and palpate the lateral epicondyle. Again, a positive test elicits pain, tenderness over the epicondyle, the lateral epicondyle. So as we can see here, alrighty. And then Modley's test is the last one. And essentially, the patient's elbow is extended with the forearm and hand pronated flat on the table. Patient lifts the middle finger up in the air against the examiner's resistance. A positive test, again, pain over the lateral epicondyle. So let's watch this here. Hand is flat, trying to lift his middle finger with resistance, and there we are. Perfect. Imaging. So, imaging, generally speaking, is not recommended for evaluation. There's a lot of non-specific findings with imaging. They've done studies with healthy patients without any tennis elbow symptoms and patients who have symptoms, and it's not a clear way to evaluate for this pathology. However, X-ray can be used to rule out alternative diagnosis, such as like fractures or anything else like that. And usually X-ray is the primary imaging technique, initial imaging technique. Ultrasound and MRI without contrast are used more for persistent symptoms, suspected tendon tears, and preoperative plannings. Usually, they could, from what I've read, maybe up to a year of pain, they could consider MRI or ultrasound. But it is also provider dependent too. Management. So unfortunately, it's hard to, tell your patients that there's not really much you could do to change outcomes necessarily in general. There's no major difference between non-operative treatment versus no treatment at all. Obviously, supportive management, pain management is important. And they've done studies where continuing the use of the affected arm does not negatively change the outcome or the course of the pathology. Usually, the symptoms will resolve within 6 to 12 months on their own. Some evidence of physiotherapy benefits, but not strong evidence. And patients can consider we could consider some steroid injections for improvement of pain, but that doesn't change the duration of the disease. And there's also the adverse effects of skin discoloration and skin atrophy. And rarely we consider surgery if it's been over a year of pain from this disease. So in summary, lateral epicondylitis is a tendinopathy rather than an epicondylitis. It's also known as tennis elbow. Results from overuse injury from repetitive excessive pronation and supination with extension of the wrist. History and provocation testing is important. Um, the key exam finding is the Cosen's test for board examinations. Usually, no imaging is necessary and management is typically supportive. Alrighty, so our second case, we're in the outpatient clinic and a 35-year-old gentleman who's a minor league baseball player presents with 5 weeks of medial right elbow pain that also radiates down his forearm. Reduced grip strength, pain with flexion of the wrist, and exam findings show tenderness to distal and anterior epicondyle. Again, shocker, it's the medial epicondylitis, also known as golfer's elbow. So epidemiology, prevalence, less than 1% of adults get this. And out of all the epicondylitis, it tends to be 10 to 20% of patients with golfer's elbow. It's significantly less prevalent than tennis elbow. Uh, Comparable rates amongst males and females, although I have read some contradictory research that males tend to slightly have more prevalence in this. Typically occurs between the ages of 30 and 50. So some anatomy, the medial humeral epicondyle, the origin of the pain, as well as the forearm flexor pronator tendons, the pronator teres, flexor carpi radialis, palmaris longus, which it's important to note that not every patient has a palmaris longus. Flexor carpi ulnaris and flexor digitorum superficialis. So etiology and pathophys, it happens through repetitive flexion of the wrist and pronation. Supraphysiologic stress on the tendon with microtrauma and degeneration. Again, a gradual process. It could also happen idiopathically. Um, Similar, considering this golfer's elbow is pretty much a sister disease to tennis elbow, very similar uh, in presentation. Um, Tendinopathy, it's not an epicondylitis, although it's named an epicondylitis, considering there's no major epicondyle inflammation. And angiofibroblastic tendinosis can be present, fibroblastic tissue, vascular hyperplasia, and disorganized collagen. Again, it's very similar to tennis elbow. Presentation. So in the outpatient realm, patients usually present with medial elbow pain, usually without trauma, gradual onset, worsens with arm use, and associated with sports like golf, tennis, bowling, football, weightlifting, and overhead throwing activities. Some differential diagnosis to consider as well. The ulnar nerve compression, medial elbow pain, and numbness to the fourth and fifth digit, uh, like cubital tunnel syndrome, and ligamentous instability, medial elbow pain, and valgus dependent laxity. So good to look out for both. Again, like tennis elbow, golfer's elbow, the diagnosis is predominantly history and provocation testing. So, for this physical exam finding, what you do is to test for golfer's elbow, you have a patient extend their arm, pronate it out, and have a flex wrist. And the examiner applies resistance, an extension resistance to the hand. And a positive test would show pain over the medial epicondyle. And another good test to look for to rule out like an ulnar neuritis is the Tinel sign. I could fast forward this video just a bit here. So essentially, you're percussing the irritated nerve. And it's important to note that you should, knowing the ulnar nerve anatomy, you should palpate or percuss along the whole course because maybe it might not be elicited at the place that you are concerned about. But a positive test would be tingling sensation. Imaging. So again, like tennis elbow, golfer's elbow, not really recommended for imaging for evaluation. There's not a lot of specific findings and reserved for unclear diagnosis. X-ray can rule out alternative diagnosis. Um, Ultrasound and MRI without contrast can be also used. Ultrasound is cost effective and highly sensitive and specific for medial epicondylitis. However, it's important to note that it's operator the outcomes are operator driven. So an experienced operator of the ultrasound will have more better sensitivity and specificity compared to unexperienced operators for ultrasound. Useful to rule out other pathologies as well, such as tears, for persistent symptoms and preoperative planning. These imaging techniques are also beneficial. So management, how do you manage a golfer's elbow? So supportive care and ice rest, some analgesics are important to keep the patient comfortable. Bracing and splinting is also important and beneficial. However, it's good to know that not to keep the patient braced for a really long time. It's beneficial for the joints to be able to move every once in a while. There's no clear guidelines for return to sports for athletes, so it's up to the clinician's discretion. Physical therapy and rehabilitation is also beneficial. You could also give steroid injections. However, as I mentioned before, there could be some adverse effects with that. And then some extracorporeal shockwave therapy uh, has been shown to be beneficial in terms of satisfaction with the treatment after 8 weeks. But during the first 1 to 2 weeks, it's has a worse pain score. Patients have a tend to rate a worse pain score compared to steroid injections. Um, Finally, if all else fails, surgical debridement consideration after 4 to 6 months of aggressive non-surgical therapy. Some exception to this rule is with elite athletes who might benefit from surgical interventions earlier on, if supported by MRI, to get back into the game. compared to the general public. So in summary, medial epicondylitis is actually more a medial epicondyle tendinopathy. It's also known as golfer's elbow. Repetitive flexion of the wrist and pronation elicit this. History and provocation testing is used for diagnosis. Usually, no imaging is necessary, and management is usually supportive. Here are my references, and thank you so much for listening today.